Hi everyone, welcome to this Diagnostic video. In this presentation we're going to talk about meningitis and give an overview of this topic. We will cover the context and epidemiology of meningitis, its causes and how it presents clinically. Then we'll address the investigations and workup needed to come to a diagnosis, and we'll talk about the management of the disease and possible complication, as well as presenting some other types of meningitis and differential diagnosis. We will then conclude with some key messages to remember. Meningitis is inflammation of the meninges, which are the membranes covering and protecting the brain. There are three layers of meninges: the outermost layer, or dura mater, the middle layer, or arachnoid mater, and the innermost layer, or pia mater. In between the arachnoid and pia mater, there is a space called the subarachnoid space, where the cerebrospinal fluid, or CSF, flows. CSF is important in the diagnosis of meningitis, as analyzing a sample of CSF gives information on the pathogen causing the infection. Meningitis is a serious medical condition, but it is relatively rare. It is most often caused by bacteria or viruses as a result of an infection elsewhere in the body. And bacterial meningitis is a life-threatening emergency requiring immediate medical attention. Other pathogens can also cause meningitis. This will be covered later in this lecture. The relative incidence of these different causes varies enormously in different parts of the world. Some risk factors predisposing individuals to meningitis are their immune status, and immunocompromised people have a higher risk of developing this illness, crowded living conditions, recent neurosurgical or ENT procedures where the meninges have been opened, such as mastoid, sinus, and skull-base operations, and recent sinus or ear infection, as these can give a route to pathogens into the meningeal space. Pathogens can reach the meninges via different routes. The most common is through the blood, with the pathogen entering the bloodstream at a distant site. Direct spread can also happen from spaces that communicate with the meninges, such as the sinuses and the ear. Similarly, recent neurosurgical and ENT procedures or wounds on the scalp or back can give a route to the pathogen. In terms of bacterial meningitis, many bacteria can cause the illness, but the most common are Neisseria meningitidis, Streptococcus pneumonia, and in children under the age of 5, Haemophilus influenza. For viral meningitis, enteroviruses, mumps and measles viruses, and herpes viruses are the most common causative pathogens. Viral meningitis is not usually as severe as bacterial meningitis. Once the pathogen reaches the meninges, and therefore the central nervous system, there is a disruption of the blood-brain barrier. This leads to an influx of white blood cells and other inflammatory cells into the meninges. These cause swelling and creation of inflammatory exudate, which can damage cerebral tissues and cranial nerves. Meningitis is often associated with septicemia, which has important implications in terms of diagnosis and management. Acute meningitis presents with a mixture of specific as well as more generalized signs and symptoms. The classic triad of acute meningitis includes fever, headache, and nuchal rigidity or neck stiffness. Presence of these three symptoms is highly suspicious of meningitis. Other characteristic symptoms include photophobia or being sensitive to light, and there can be alteration in the level of consciousness, irritability, and sometimes seizures. Signs of meningism or irritation of the meninges are also characteristics. Two specific signs are often positive in meningitis and can be elicited during physical examination of the patient. The first sign is a positive Kernig sign, where extension of the leg at the knee causes pain and prevents full leg extension to be achieved. The second is a positive Brusinski sign, where flexion of the neck causes flexion of the leg. More generalized symptoms, such as malaise, nausea, and vomiting, can also be present. Symptoms tend to be more severe in bacterial meningitis than in viral cases. A specific sign of meningococcal meningitis, often accompanied by septicemia, is the presence of a non-blanching, purpuric or petechial rash. A glass test can be performed to confirm the non-blanching nature of the petechiae, as shown in the picture on the right. This involves pressing a glass against the skin and observing that the rash is still present. A number of investigations should be carried out to diagnose meningitis. Firstly, blood tests should be taken and a full sepsis screen carried out. Full blood count, liver function tests, blood glucose levels and electrolyte levels should be requested. Serum lactate should also be measured as part of the septic screen. This is usually elevated in sepsis. Blood samples should also be sent for culture. Swabs should be taken from the throat for both bacterial culture and virology. After blood samples have been taken, empirical antibiotics should be started promptly. A lumbar puncture should be performed as a diagnostic test. A sample of cerebrospinal fluid should be sent for microscopy, culture and staining. Gram stain should be performed to assess presence and type of bacteria. Glucose, protein and white blood cell levels should be analyzed. Normally, a lumbar puncture can be performed without neuroimaging first. However, if the patient shows signs of raised intracranial pressure, or ICP, such as papilledema, then a CT scan should be performed first to exclude the presence of mass effect. Cerebrospinal fluid analysis is a very specific test for meningitis and can help distinguish between various causes. Being able to interpret a cerebrospinal fluid profile is useful in diagnosing meningitis. In normal situations, the CSF is clear. It has a low number of white blood cells, which are lymphocytes only. The CSF glucose levels are above 60% of the blood glucose levels. The opening pressure, as measured at lumbar puncture, is low, between 8 and 15 millimeters of mercury, and protein levels are low. These values are altered in meningitis. Bacterial meningitis is characterized by a turbid or purulent CSF, with elevated white blood cells and the presence of neutrophils. Glucose levels are low, as glucose is a substrate for bacteria, and protein levels are high. Bacteria can be seen in a CSF smear and in bacterial culture. The opening pressure is usually increased. Viral meningitis has less stark changes, with the CSF often looking clear or slightly cloudy. White blood cells are increased but still lymphocytes. Proteins are elevated. The opening pressure is usually in the normal range. Treating meningitis promptly is crucial to achieve a positive outcome. Empirical antibiotics should be administered as soon as possible after the blood samples have been taken for analysis. Local guidelines may vary, but the antibiotic of choice needs to be able to penetrate the blood-brain barrier. Usually, ceftriaxone is used and is administered intravenously. Once the culture results are available, antibiotic therapy can be adjusted to target the causative agent more specifically. Viral meningitis is often self-resolving, and supported treatment alone is sufficient. If the causative agent is a herpes virus, then acyclovir can be administered. If the predominant symptoms are those of meningism, then a steroid such as dexamethasone can be administered. Supportive treatments include fluid maintenance regimes, oxygen to maintain good saturation levels, and preventative measures such as seizure prevention medication and airway preservation. Meningitis prophylaxis should be considered for any close contacts of the patient. Although most people fully recover from meningitis, complications can develop both acutely and chronically. In the acute phase, complications associated with sepsis can develop, such as severe hypotension and shock, low oxygen saturation, and cardiac arrhythmias. Supportive treatment should be used to overcome these problems. Additionally, patients can experience exacerbation of chronic disease, and they can develop cranial nerve palsies or stroke due to disruption of the brain blood supply. In the longer term, individuals can experience temporary or permanent sensory neural hearing loss, mental impairment with memory and cognitive deficit. Recurrent seizures can develop, as well as hydrocephalus or focal neurological deficit due to inflammation and scarring caused by the illness. Bacterial and viral meningitis are the two most common types. However, there are also other causes. Chemical or sterile meningitis is a non-infective form of meningitis that arises following neurosurgical procedures due to irritation of the meninges during the operation. It is very rare and mimics acute bacterial meningitis with regards to symptoms. However, no pathogen is found during the diagnostic workup. Treatment is symptomatic and includes steroids such as dexamethasone. Tuberculous meningitis can arise in individuals that have tuberculosis. Symptoms can present acutely, but also subacutely over several days. If tuberculosis is suspected as a cause of meningitis, a chest X-ray should be performed alongside the normal diagnostic workup for acute meningitis. When a lumbar puncture is performed, the CSF can show webs of fibrin. Diagnosis is challenging, and treatment is prolonged and consists of antituberculous agents such as rifampicin, isoniazid, pyrazinamide, and ethambutol. Fungal meningitis is another rare form and can arise in immunocompromised individuals, for example, HIV-positive or cancer patients. Various fungi can cause meningitis, but Cryptococcus is the most frequent. Symptoms usually develop gradually, and treatment consists of a prolonged antifungal regime. In summary, acute meningitis is a serious medical condition requiring prompt investigations and targeted treatment. In particular, acute bacterial meningitis is a medical emergency, where prompt diagnosis and treatment can save a patient's life. It is important to remember the classic triad of meningitis symptoms, which includes fever, headache, and neck stiffness. Meningitis should be considered as a differential diagnosis for a patient presenting with sepsis. You should familiarize yourself with the sepsis 6, which are key elements of the diagnostic workup and treatment of suspected acute meningitis. The sepsis 6 are: number 1, give high flow oxygen; number 2, take blood cultures; number 3, give intravenous antibiotics; number 4, give a fluid challenge; number 5, measure serum lactate; and number 6, measure urine output. Remembering these steps will help you diagnose meningitis and can help improve a patient's chance of survival. This concludes the video. We hope you enjoyed it and thank you for listening. There are many additional resources that you can use to do some further reading on meningitis. Here we name some of the resources we found useful. This includes some websites, key research paper, and textbooks.